agendas and Word documents and such like.
Sounds good.
So
We're getting to the home run, which is exciting.
yes, no, it is. And it does sort of, I think I do feel the pressure for a little bit more rigor now, because we have to deliver a finished product. So enough chit chat. We have to actually give
Do some
a,
work.
give a high quality product to our state colleagues. So, but yes, no, it's
Confident in our abilities and in your
oh
leadership.
yeah, no, no, for sure, for sure. And, I think we've for sure, and we've come up. I'm just looking at this document. We've come up with seven um, recommendations at the so far, and we haven't discussed the last point as well. So we'll wait a few more minutes and then jump in.
Sounds good.
I apologize that I have to go around 12:30 because of monthly office research meeting I have to co-host.
Oh,
Sorry about that.
12:30 or 1:30?
12:30. Oh,
Oh,
it's
like
one at one, sorry, 1 to 2.
oh, wait, one. Oh, okay.
Sorry
Of
about that.
course. No, of course. And, I know we're booked for quite a long time. I think 1.5 or 2 hours. But in general, I'm hoping that within an hour we can discuss what we need to discuss. But of course, if we need more time, that's fine. But an hour is usually quite a long time to um, work through things. Hi, Jorge. How are you?
Good, I'm doing well. How are you?
Good, thank you. I was just thinking how rarely we meet because when I saw you at the obesity meeting, I hadn't realized how tall you are. So I don't know how tall you are, but
Yeah,
you're obviously tall. So I was like, oh my goodness, I had no idea.
no, that's funny. Yeah, no, I hadn't actually met Boo Boo until the meeting. And
Yeah.
it's all these
Really?
meetings
And yeah,
in person. We haven't.
you must have had 30 conversations by
We
then.
did. And so we weren't quite sure whether we'd met before because we saw each other on Zoom so often. We just presumed
Yes.
we had met, but we actually had never met in person.
Well, I think with Jorge, it's sort of easy to notice the first time because he's very tall, right? So all of a sudden you're like, you kind of make assumptions that people are average height, and then so that's great. Should we kick
Funny.
off? We're at about 4 minutes past. I'm not sure. Um, Actually, no, we're clearly a few people haven't logged on yet who I know are expecting to, so we should wait. I think Dr. Dawson had said that she would. Oh, you are there. Sorry,
Yeah, yeah, she's here.
you're there. I'm sorry, your camera wasn't on. So should we start then? Maybe.
I think we
Okay.
can start, yeah.
Well, welcome everybody. So we can. The meeting is convened. And as we have obviously come up with several proposals, seven to be specific. And I had circulated these. You've seen them all before, and then we sort of formally circulated them again on Monday. So we can go through them individually, but we have discussed them before. It might be more time efficient just to ask if anybody would like to speak about a particular one or make any particular changes. Or we can go through them individually, whatever people prefer.
You want to run through them real
Yeah,
quick?
okay, let's briefly run through them. So, and I'll just go through them in the order that I've listed them. So, number one is to establish a system for screening the electronic medical record at obviously in Connecticut, to identify individuals and groups of individuals at high risk of MASH. And this speaks to, our mandate to somehow screen the population, right? And obviously the word screen is super broad and can involve lots of things. And screening the electronic medical record seemed like a practical way to advance, which would not require a huge amount of resources, as opposed to obviously going out in the world and screening people. So I think this is fairly non-controversial. All along, what we haven't done, and maybe we can use this as an example to discuss that, we haven't given sort of practical guidance on how to do this. So, for example, obviously, Epic medical records is used by many healthcare systems. We could give practical guidance on how to screen Epic and, put information of contact people and such like, and we haven't done that so far. because I assume that would be coming in at a later stage, right? If any of these get converted into builds, at that point, the nitty-gritty of how would you do that, what sort of resources would be required, I think that's when that would come in. Peter, I'm not sure if you can guide us on that, or do you think this is the stage to start putting in nuts and bolts? You're muted if you're
I
okay.
don't know if it's
Maybe
there,
he's
but
maybe
yeah,
he's having a
I agree. I think maybe more broader picture, big picture for now, and then we
okay. Okay, because these are recommendations at that point. These are not one of, how to execute these. Hi there,
Hi,
sorry.
sorry, I was away for a little minute.
Oh, no problem. But it was just sort of a general question that, you may have had a chance to see some of the recommendations that, for example, the first one, which is to screen electronic medical records, along with the recommendation, should we also give more information on the practical steps that we should be taking to make this happen or not? I don't
I saw
know.
that I saw that Representative McCarthy Vahey joined, and I think I would refer to her because I feel like she
Oh,
would
of
know a little
course.
bit more.
No, of course, of course. Hello, how are you?
I'm so sorry. I joined, but I did not hear.
No,
I
no. Of
apologize.
course,
I'm
we no,
catching up.
we just started as well. So, it's a general point. We currently have 7 recommendations, and the first one is sort of a simple recommendation, which is to establish a screening system for the electronic medical records to identify, individuals and groups of individuals at high risk. And the question or guidance we need is, should we add practical steps also as to how this would take place, or just leave it as a recommendation?
As I do think that having any specificity in terms of practicalities of how that could happen could be helpful, but I
Okay.
don't think it's necessary.
Okay. Thank you. So I guess one thing we could do is, in this case, for example, we could identify the main electronic medical record systems that are being used in Connecticut, and maybe some contact information for some of the people there. So,
That sounds good.
okay, great. Well, thank you so much. Okay, so there's 7, so we've discussed them before, so I'll plan to move through them fairly quickly, but please do stop me if anybody would like to add something or, make any sort of comments.
So Wash, just in regards to what you just said, so are you proposing that we provide contacts for each medical system? Or how would we do that?
Based on what was just suggested to us, I would think any level of, sort of granularity or any sort of practical help we could provide, so for example, for providing an EPIC contact for Yale New Haven would be relatively simple. And in fact, now that I think about it, the contacts would actually be for the public health contact for the healthcare system, right? So obviously I know who that is for Yale New Haven, but each healthcare system is going to have an Office of Public Health. So probably providing the contact for them, because any sort of screening of the EMR would have to go through the public health point person
Right.
for that
Okay.
healthcare system. So I'll
Sure.
just make some notes on that as we go along. Okay. All right.
And
I,
also,
I have a general question before we move on for this point. Does EPIC extend into the rural areas as well? Because I know we talked about health equity and wanting to capture, Hispanics and other minorities that are more at risk. So I just wanted to know, a large EHR system like that, does it extend into those rural, lower income areas?
It'll extend into wherever the healthcare system has any sort of an outpost, whether it's a primary care clinic or any provider whatsoever. It could be a vaccination clinic, literally any sort of a presence that a healthcare system has. The EMR would be built into that. But of course, if there's simply no footprint at all, then it's just it's a gap.
Okay.
And that's a relevant point. So, and also, even in an area that, you know, well, New Haven is a good example, right? We obviously have a massive hospital sitting in New Haven, but if a group are uninsured and simply don't make any sort of contact with the healthcare system, then they'll be invisible to the electronic medical record system, right? I mean, you know, and of course we all know that the unfortunate situation is that, you know, people from in that situation often only pop up in the emergency room. I mean, even then they'll pop up in the system, but obviously that's not how one clearly wishes, you know, our healthcare to be delivered. So, but short of an emergency room visit for a broken leg or whatever, they'll be, you know, for normal health screening, for lab tests, for ultrasounds, they'll be invisible. And to be honest, on that front, even if their name and address, etc., you know, they were in the EMR just as obviously as an individual, but there was no medical information in there, like there were no lab tests, no ultrasounds, then for the purposes of this purpose of identifying, you know, fatty liver disease, they would still be invisible because there's basically no information there. So it's just a huge problem, definitely.
I think that's why we had proposed the prospective study go out and screen, but of course it's a different level of commitment and you know, financial undertaking. I think Hong and Elizabeth also had some
Yes,
comments.
please.
Oh, yes. Regarding the high risk, I think we discussed in our previous meetings. I was wondering going forward, we will talk more about how we define high risk population, what kind of data or parameters we are looking for if we were to have the EMR databases.
So again, that goes into the specifics of how an EMR search would take place. And that's, you know, that's a relatively complex discussion, as you well know. I mean, this is, in fact, out of all of us, you're the expert in that area. We could give some guidance at this point, or we could leave it to the point where, you know, the public health individual, say for Yale New Haven or Hartford Health, is contacted. I'm open to your suggestion, whichever you prefer. We could give some guidance in this document, you know, a paragraph, shall we say, or a short paragraph.
Yeah, maybe we can mention a few key risk factors.
Okay.
This
Would you like to
particular.
share that with us, or should I
I
put
think
together?
you and Bubu knows better than me, but I was thinking
No, I
like the
know.
risk
Okay.
We'll put something together. Yeah,
Yeah,
I think
okay.
Yeah.
that would be appropriate. Yeah.
Okay, so high risk definition. Okay. And we can actually jump to point 4. So did somebody else have any comments
I
about
think
this?
Elizabeth had a
Yeah.
Yes, I just had a quick comment to add on to Dr. Dawson's comment about health equity. I know we're speaking broadly about healthcare systems, but if we're trying to reach at risk in your details, do we want to say including like federally qualified health centers, like so that it's, you know, they are sometimes in the outlier towns. I know we're looking at cities, but I think if you are trying to give some nitty gritty and trying to give some general, make sure we're extending it to those.
Okay.
I don't know if they use Epic or not. Honestly, I don't know what FQHCs
Well,
use.
it doesn't have to be Epic. I mean, it's whatever their electronic medical record system is. I just mentioned Epic because that's, you know, that's what we use. And it's the most common, but you know, it could be anything. I mean, obviously this wouldn't go into the VA, which of course is federal, but I mean, that has something called CPRS, and there are other EMR systems. And I'm just going to mention number 4 because it's closely related. And I'll just read it out. It's just 2 sentences. Initiate prospective screening using FibroScan for liver fibrosis in high-risk areas. These will be predominantly areas with poor access to health foods and high Hispanic populations. And this is obviously the real world, going out into the community, you know, taking equipment into the community to people who otherwise are invisible. And unfortunately, we know there are lots of people who have disease and are completely invisible, right? At the same time, of course, this would require, significant resources, right? I mean, it'd require FTEs, it would require purchasing equipment, it would require all the resources you would expect. So I think it's important to put it out there. I'm sure it comes under sort of aspirational rather than something that would happen, but at least we can put that. And this is really what should happen, right? I mean, this is what we would like to see happen. So, okay. So 1 and 4 cover sort of screening aspects of it. Number 2 is much broader, and it is to develop a broad outreach program to educate. And we've identified 3 groups about obviously liver health. So one of our colleagues in primary care, one are essentially our colleagues as teachers, and then the third are students. So before we move, and then we go into how we might do that, but are there any other professional groups that we would like to target? I mean, the other obvious ones are subspecialists who would have similar populations, for example, like endocrine being the obvious one in diabetes clinics, or cardiologists in ischemic heart disease clinics and things like that. But I think if we can approach these 3, we would already be doing quite well, was my feeling.
Were you going to include pediatricians? I know we talked about that last time when you say primary
No,
care.
that's true. Let me I did my intention was that, but let me be explicit about this. After primary care, I'll put specifically pediatricians. Thank you. And then we just give a few examples, and the very obvious ones, radio ads, teaching materials, outreach programs. And then I listed 5 key points to get across. I won't go through all 5 of them. They're in your write-up, but these would be sort of the key educational points. And you have these, and you can, again, if you wish to add any other points that you would like to highlight in this process. Actually, more than that, we had up to G, sorry, more than that, more than 5, 7 points. And then we had some references when we use terms like lifestyle intervention and social determinants of health, and identifying food deserts. We have just some references to give some material there to help with that.
Can I add that I think number 6 could easily be folded into number 2 as part of that outreach and education to PCPs and pediatricians in schools, because you're talking about
Okay.
the sugary drinks. If you're
Right,
talking
right. So that would, I
so
guess,
general public too, but if you're going to do some targeted, like,
yes. So that means that would come under, I guess, lifestyle in a sense. The only reason we separated out 6 was just to sort of particularly identify the or highlight fructose and soft drinks, as it were. But we could highlight.
it could stand alone too. I'm just saying it would be
Yeah.
a miss to not include it in that.
Yeah, well, we could do both, right? We could include it in, I guess it would come under lifestyle. I mean, food deserts is more a lack of healthy foods, although it obviously at the same time it is an over preponderance of unhealthy food, the both aspects. But I could put it in lifestyle. I will add it to the lifestyle intervention E.
I think the general public could benefit from it too, but I just think if you're gonna like talk
Yep.
to them,
No, for sure. But number 2 will obviously require, frankly, just a lot of time and work, right? Because obviously preparing any sort of material. I mean, I've prepared something as simple as a trifold, and it's amazing how much work it is to prepare a trifold by the time you've got the photographs and had the text approved by everybody. So you'd think something like a trifold would be a few hours work, but actually it's more work than it seems. So everything under 2 is actually going to be a tremendous amount of work. And from a practical perspective, I guess we should just simply ask in an open sense, who would do that, right? Yeah, I mean, quite simply, who would do that? Even if we take something simple as a radio ad, or say a trifold. I mean, I can imagine 3 types of trifolds, right? Just a simple 1-page trifold, one for primary care, one for teachers, and one for students. Who do we envision would actually prepare that? And I'm asking because I just don't know the system, the state system beyond what we're speaking. Allison, you can say something.
I mean, we have dietetic interns I know that are able to help with certain parts as far as from the lifestyle and nutrition aspect. They have to do certain projects for part of their internship, which
No, that's great.
as a requirement, they could do that for trifold. I know that was something we definitely had to do for our internship requirements, so they
Oh
could
no,
help with
that's
that
no, thank
aspect.
you for that.
Yeah.
And I mean, there are many people on the call who have the ability to contribute. I guess I was asking more from a Jorge, but I was just thinking, I was asking more from a process perspective, right? I mean, once this goes to the public health committee, who picks up on that and then approaches people? Sorry, Jorge, you've got your hand up.
I was going to add, what about community health workers? Have you guys talked about that in the past? Because I think Connecticut has community health workers, which are individuals that have more on the ground access to patients. So I actually don't know the numbers in Connecticut. I know in other states they're pretty large, but I'm sure the Connecticut Department of Health has worked with community health workers in the past, so they might have some idea about um, how many of them there are and how to connect with them for these kind of outreach programs.
Okay. Now, are these state employees? Are they employees of one of the healthcare systems, like Hartford Health?
I can speak
Yeah.
about community health workers. I work with the Office of Health Strategy, which is a state agency, and they worked heavily the last few years to get the licensing for community health workers. So as Dr. Moreno said, community health workers are kind of a catch-all word for people that might fit health education, screening, outreach, health navigation. They often go by various names. So we use them within some of our diabetes and cardiovascular disease programs, but they're hired by either a healthcare system, they're employees of the whatever agency, but they tend to be bilingual, which is helpful. They know the communities, they know community services. They're the community clinical linkages between the clinical world, and they often help with like health literacy and making information understandable for someone after having a doctor's appointment and stuff. So I definitely was thinking about that as well as a potential group.
So can they be approached as a group? Because if they're sort of scattered amongst different health facilities, how would one approach them? I mean, is there an office of community health workers at Hartford Health, for example?
There is Connecticut there's about 400 licensed community health workers. That means they've gone through all the regulations to be certified by the state as a licensed community health workers. We're in contact with the Connecticut Community Health Worker Association, who handles some of the listservs, trainings. So I can certainly give you that contact.
Okay, wonderful. So there's a Connecticut Association for them.
Yep.
Okay.
There's an advisory board as well. So.
Okay, excellent. Thank you so much. No, that sounds perfect. But again,
and I think to finish that thought is if the legislature creates a fund of some sort, or puts this in, once we come up with the final recommendations, they may have the funds, if we ask them or recommend them, for one or two community health work, just as a starting point. Some community health workers that focus on liver health, maybe in the high yields populations like New Haven, Bridgeport, Hartford, as a starting point. And so that kind of thinking of how to put two worlds together is, we could link them, and then eventually, if there's like a fund source for them, then they could be part of the outreach that the department does. In addition to Hartford Healthcare, in addition to Yale having their individual people do that, but kind of just like thinking how it all could come together.
Okay, no, that's very practical. So it could be, as part of the highlighting amongst the currently working community health workers, as well as, should we just go ahead and recommend hiring 2 community health workers, but that would be state employees that would focus on liver health? But if they were to do that, who would they report to, Elizabeth? Like, I mean,
usually community health workers are not DPH employees. They're part of a healthcare system like Yale and FQHC. So we
Okay.
don't currently have community health workers that are employees at the state.
Because
So they
you don't have
need
a
to follow the
structure.
direction because they need to be connecting someone to a healthcare system.
I
Usually-
see. I see. So would a proposal to fund, say, 2 community health workers be practical then? Because essentially the funds would then have to go to one of the healthcare systems to employ this individual, right?
In theory, yeah, it would
Yeah.
be, they should be connected because if they identify someone that they've been out there doing education screening, they want to have a physician or a healthcare system. So maybe I think developing tools first, like,
Okay.
and then I
Okay.
think you can put whatever you think is best in there. I mean,
Sure.
as
Well, I'll
the
write
might be
something
the
in it.
next level of conversation that they ask, how do you envision doing this? But
Sure. Okay. No, but thank you. I think both of those the community health workers were just a blind spot for me. Okay. But so that's one example, but all the others like radio ads, just trifles. So if the Public Health Committee decides to move this forward, then what would that look like? I mean, would that be that the state would, I don't know what the state would do. Would they pass a bill to say that we need to have outreach? I mean, because I want to make these recommendations practical, right? We don't want to just say something which,
Maybe Senator Kristen McCarthy, but you can depending on what's happened before in the other.
yeah.
May I jump in for
I know,
just
of
a
course,
moment?
please, anytime.
So unfortunately, I am going to have to leave for another meeting in just a couple of minutes, but I think that, a lot of these things, especially those things that will require funding, will be much more difficult to get through on any level, whether it is legislatively with a bill or through the executive branch in the department. I think that worrying about the specifics of those pieces maybe isn't as important as just the general sense of here's what we're
Okay.
hoping to achieve. And then if we were to put a bill forward on any number of the recommendations, there would be a bill process that would really flesh things out.
Okay.
Or alternately, if the department were to take up some of those recommendations, that would be something that would go through that process. So
Okay.
I do want to say before I have to sign off, thank you to all of you for the investment and time and effort and energy that you have made in making these recommendations. I believe that just by having these conversations, we continue to raise awareness and help people understand the issues. I certainly have learned quite a bit from all of you. And I look forward to continuing to have conversations and work with all of you in the future. Thank you.
Okay. Thank you for your support. Thank you so much. Okay, so based on what we were just advised, I think what I'd like to do is for every recommendation that will clearly require funding is to have that as a separate recommendation, because obviously if that's not going to, well, it's going to be more difficult to move that forward. I wouldn't want there to be like a composite thing so that it's just the whole thing just doesn't move forward. Okay, so when I rewrite this a little bit, I'll make an effort in terms of, hello, welcome. I'll make an effort to separately identify recommendations. I mean, almost everything is going to require some level of support, right? But at least we can separate that out. So item number 3, I think to me is hopefully, what would be a no-brainer and perhaps one of the more impactful ones, which is to designate a Connecticut Liver Health Day. I mean, I think its impact is sort of a soft diplomacy impact, because by designating a day, in some ways what it does is it focuses every other group in the state that has an interest in fatty liver disease to obviously focus on that day, and then they may be able to bring up their own resources to make that happen, whether it's people resources or whatever other resources they might have. And at the same time, I don't think that designating a day as a Connecticut Liver Health Day would require the state to come up with resources. Maybe I'm being naive, but if anybody knows, please let me know. But
I would think it depends on the level of,
right.
commitment. Yeah. So,
Right.
so I agree that it can be done with minimal resources, but at the same time, if there are resources that would help even
No,
police.
resources, of course, would clearly help. But I mean, designation in my mind is one event, which is sort of like just a designation, and then acting upon it in terms of whatever else, we wish to do or the state wishes to do in terms of radio ads or anything else is a whole separate sort of thing. But I guess what I'm thinking is since I sometimes things that appear simple are not simple, I'm just not sure if simply designating something as a day itself generates cost. Like, it's like, well, if you know, change the speed limit from 55 to 54, then you've got to like print 3,000 road signs and blah, blah, blah. So things can seem super simple, but actually there are costs hidden in there. But anyway, we'll go ahead and say that. And I'm actually, out of all of these, maybe because I'm hoping that this will move forward because it seems like a obvious low cost thing. And then also because it will clearly be visible. I'm very excited about that. And then also we've already had some communication with national level with American Liver Foundation, and they would be certainly very interested in, once such a day is designated, then sort of focus their resources on that day as well. Um, so there's that. Okay.
I just wanted to say quickly, I don't know if it's necessary to know anything of it, but if they are able to approve that, it'd be nice to link it with number 2 for when you actually distribute any of those materials.
Oh, yes, for sure. I'll make a point of that.
I do think even at the minimum, resources are needed to spread word about the day, right? Whether it's flyers you're making
Yep.
or announcing it on the radio or the TV, you do need maybe to buy airtime or something like that.
No, for sure. So what I'll do then is split that into just make another recommendation. One is just to designate the day, and then a separate recommendation for resources for
Right.
all of the things.
So if you could use those materials that are going to educate, they might cut down on the costs of having to
Right.
talk about the day being or occurring, I guess, for the first time at least.
Yep. Okay. And that always happens. Once you start building something, then obviously the components start fitting into each other. I mean, one thing I hadn't thought about since obviously the word resources keeps coming up is outreach for donations. I'm sure, actually, I don't know. I don't know if the state, I mean, obviously private institutions like Yale obviously has, outreach programs for donations from whomever, wealthy individuals, whomever. I've always assumed the state doesn't have a structure like that, does it? It doesn't, the state of Connecticut doesn't go to wealthy people and say, give us some funds. Okay. Anyway, we can keep that in mind. So there's that. Number 4 we covered along with number 1. But actually, before we move away, Dr. Dawson had done some background work as well with the CARE Alliance. Would you like to share some of that at this stage before we move away from outreach stuff?
Sure. I did reach out to CARE. Of course, they're in both the College of Health and Human Sciences at Southern Connecticut State and over at Yale School of Public Health. It's a partnership. And I mentioned the Connecticut Healthy Liver Day and what we would like to do in terms of a partnership and educational outreach. I'm just waiting to hear back from a contact person so I can connect them to this group. But I feel like it's very promising because this is what they do already.
Yeah, I mean, your email was actually very encouraging. And the website that you linked to your email, because it does seem like this would be the type of thing that they might want to take up. Obviously, I don't know very much about them. Do they mostly do information gathering, like epidemiological data collection, or do they go out and are involved in teaching the community or everything?
They do a number of stuff, and don't want to do them a disservice by cutting them short with their mission, but I do know they do, a number of data collection, research, definitely education outreach, even more practical things like going into the community and mobilizing community members to leverage them to talk to members of the community, neighborhoods that they've targeted and really built that relationship. So they offer a gamut of services. Even I think they had an initiative where they help with sidewalks. so
Okay.
that people could have, opportunities to exercise more. So they do, kind of this higher level research portion, but also more practical hands-on approaches to communities, which I think will be really helpful for the day that we're planning.
Okay, fantastic. That's fantastic. And certainly then if they look up with something like the American Liver Foundation, then there could be additional synergy. So did somebody?
Hi, this is Alicia.
Yes, hello, welcome.
Thank you. So one of the premises for CARE is if I go into the community in which I live, that I work, and people see me, they're more apt to respond to and take the information that we're giving them in regards to care. So you kind of work with the resources you have, with the community that you have, even if you door knock in your own community, to give out information and have people have and you also have it so that they have a link to go to learn, to get information. Because of course people are going to be hesitant. So then you have, okay, this is definitely legitimate. This is where you can go to get more information, and then reach out and give me another call. Different fairs that are in your area, you will go there, you have a table to give out information and have people, make your table look inviting so they will come and get more information in regards to whatever information you're trying to teach the community. So then they can go and advocate for themselves and get either vaccinated or get the level of care that they need. So it's really to empower the community in which you live.
No, that's great. And everything that you're saying obviously makes tremendous sense. But that you're sharing that with as a perspective of how CARE generally approaches such community outreaches. Is that their typical model?
Yes.
Okay.
Yes.
Okay.
Yes. Other than the other, as the previous person had said, that they also, gather data, numbers, so that we have supporting documentation to support what we're trying to do as care workers in the community.
Right. No, that's tremendous. That makes, as you were saying that, for some reason, Tupperware came into my head because Tupperware was sort of like a community outreach, right? And it was, I know it's dated now, but it was like a massive phenomena in the 70s and 80s, which is ultimately community outreach. You just go with your little Tupperware thing and share it with your neighbors, and it was a massive phenomena. Okay, no, that's fantastic. At a very small level, when I've tried to do it myself, obviously, when I visit friends, and NASH is so common and obesity is so common that, of course, I'm sure all of us know individuals and friends and family. You kind of get not blown away. They kind of get ignored a little bit because you're friend and family, you know. So there is that other side of things as well, that having. So maybe we could do both, have, friends and family approaching other friends and family, and also have professionals coming in as well. I think that would be good. Okay, great. Any other points before we move on to 5, 6, and 7? It's been a good discussion actually, because then, we had discussed these before, but there's so many nuances that new things keep coming up. So this has been good. So number 5 is really just highlighting the specific risk of fructose in the development of MASH. And the reason I've selected this is, of course, we all know excess sugars are bad, but fructose in particular, for various biochemistry reasons, is particularly bad. So we were going to try and identify the top 5 points of fructose delivery to Connecticut residents, which will be a process, right? I mean, that would require some research into how this is done. In relation to this, there was an email which I'd asked Peter to forward only a little while ago. I'm not sure if any of you folks received it yet. I only requested it just a few minutes ago, because I had a response from, let me get the person's name right. Excuse me. From Susan Fiore, who is an education consultant, and is also MS and a dietitian as well. And she actually, in this email, either has or soon will be forwarded to you, basically gave a very detailed response along with references for all the rules and regulations that are pertinent to sort of soda in public school places. So, and I'll just read the first line of that basically, which is that students' access to soda in public schools can never be sold in cafeterias, vending machines, or school stores. Okay, with some exceptions. And then she's provided links to the documents where the exceptions are. So not surprisingly, this issue has been addressed. I mean, I'm not surprised it's been addressed because obviously it's an important issue. What can we contribute to this conversation? I guess I'm not sure, except maybe just to highlight that for NASH is a particularly high risk, you know?
I think there's still quite a bit of room. I mean, they're trying to make the added sugars adjustment by 2027 for less than 10% of calories for school lunches. But I mean, I have 3 kids in school, and I can tell you there's a distance to go for
Okay.
the added sugars portion. I mean, I'm not sure if anyone else has children in school, but their
Not
breakfast alone is well above that.
okay. So what would you suggest? I mean, I don't I'm I'm never in favor of sort of stating the obvious because sort of what's the point? If someone said the same thing 3,000 times. So I'm just thinking about what we might be able to contribute more uniquely.
I think if I can just, this is just a suggestion, but because liver health is such a new concept for people, as we've mentioned before, it's not something commonly talked about. People know about heart disease, diabetes. But if you're going to have an intern or somebody potentially make outreach material and it talks about healthy lifestyle, I don't know why you can't just use that caveat notice about things with high fructose corn syrup are make you more at risk.
Okay.
Read food labels and not, so some examples include sugary drinks like soda, but I know there's fructose syrup in so many things in that way, instead of like listing them, but you can give a couple examples if it's going to be given, not just for students, but if you think you're going to do outreach for the general public or
Okay, no, that's a good idea.
doctor's offices, because those are really your starting point. If you can say like, hey, did you know that you may not know you have fatty liver, but if you drink a lot of this, you eat a lot of, like that's part of that lifestyle.
But that's excellent.
Keeping it simple as a starting point,
Yeah,
like
no, that's excellent. So, well, I'll do that. I know this is being recorded, but I'm just sort of making side notes as well for myself. So basically link this to the materials as you suggested. And there may be items, because I just don't know, that are not so obvious as soda, right? I mean, everybody knows soda, but there may be other items that I simply don't know that actually have a lot of fructose in them that we can highlight. So
salad dressing, some granola bars. I mean, I'm sure the dietitians here on the
well,
call
that's what
can
I was
certainly
gonna
add all the like top 5, like.
yeah, I was staring at Allison, but I know you can't tell on the Zoom screen.
I can think of pancake syrup. My kids love
Yogurt.
pancakes.
I was gonna say for the breakfast items alone, I was gonna say there's a lot of more sugars added to, especially their more, well, I'm not sure from school to school from it, but for more of their like their muffin type items that they have, that they
Right,
have
right.
them in there from it. And I'd say some of their cereals that they're added in there from the sweetened options, depending on what they're doing for their fruit cups. I know some of them, I looked at some of the schools in this area from it. Some of them are claiming that they're in water versus others, I think you could assume, are probably in more of the syrupy
Syrup,
type
yeah.
items, which those are a staple because I understand that they're limited budgets for the schools. They have to work on certain things to hit their criteria. They have to have 5 fruits during the week. And that's a big thing, is the fruit cups are quick, they're easy. They can throw them on a tray. They don't have to worry about allergen contaminations and things like that. But if we're
Okay.
able to even influence that as far as just having them be in water, that would be a tremendous change for those kids to not
Right.
have
So,
those.
no, so, a fruit cup where the fruit is basically covered in syrup counts
Yes.
as fruit?
Yes.
Oh.
Sorbet counts as a fruit for some of their lunches.
Oh, I've been having a very healthy diet and I didn't realize it.
Yeah. Fruit
So,
sorbet counts as one of
so,
their fruits.
my goodness.
Yeah.
Okay. Well, that's sad, actually. That's very sad.
Yes. I was gonna say I could pull up
Kind
their
of-
lunches if you want to see them in their
No.
breakfasts, but
Yeah.
they're
Okay.
what counts as it is not what I would designate, or I think any dietitian would designate as a fruit. But I get they have to work with certain things that they're given.
Right.
I understand
Right.
it's budget versus
Of course, of course. I mean,
nutrition.
you have to be realistic about it.
Yeah.
And again, this topic, obviously, I'm sure, I mean, I have not been involved in the discussion, but I'm sure there have been lots and lots of discussions and
Yes.
regulations, and this is very not contentious, but certainly well discussed topic. So that's why I sort of keep coming to, what's new that we can provide, right? Because just saying the same things again is not probably going to get us much traction, and which I guess has to be the liver angle, really. That's the new thing.
I think that's the biggest, is if they're seeing it in kids at a younger and younger age, if we can make an impact on those kids at a younger age, I think that's where I see it being a huge
So let me
alternative
then,
to
I
it.
think, definitely attach some pediatric NASH references. It's one thing just to say stuff, it's another thing to actually, back it up. So let me make sure that the documents we've sent to the Public Health Committee has some, not just, references, but maybe PDFs of articles and
Yeah.
such like, so they're easy to get hold of.
Definitely.
Okay.
And in public health, we tend to really want to empower people with the knowledge so they can make the healthy choices themselves. So I didn't know myself until I joined this work group, and I work in diabetes and grants on heart disease. That's never come up from the information that I've been receiving. So I'm really taking what I'm learning here and sharing it with my team.
Okay,
But the
great.
general
Thank you.
public should really just general, like this is a starting point. Maybe not drink soda, but drink less of it. Because if you, like,
Right,
empower
right.
them to know that this puts you
Yeah.
at risk so they can make some educated choices, read the labels a little bit more, things like
Yeah.
a
No, you raise an excellent point, because I think, I'm thinking about, the clinicians, the liver clinicians here, which is Boo Boo and myself, that, we've been so focused on our patients, not surprisingly, because this is an epidemic and our clinics are filling up with it, that, I think as a hepatology community, we haven't put that much effort into public education, which is sort of what you're saying. So,
I agree. And I think a lot of us physicians, like you say, we focus on the patient when they come to see us in clinic or in the hospital, but really not beyond those borders.
right. And our professional organizations like ASLD, again, focus on us.
Right.
The hepatology members, they don't go out and focus on the community quite so much. So, okay. So number 6, we've sort of covered in through other aspects, which is communicate with soft drink providers that there's a state level recognition. So I guess to be more specific, should we say send a letter? Can we say that? Because communicate could obviously mean anything. So, who would that be? Would that be the chair of the Public Health Committee? Perhaps you can be specific, like recommend that the chair of the Public Health Committee write to soft drink companies and highlight this, or is that too specific?
I can't speak to that,
No,
and
okay.
having not been on something, to that level.
Okay, I'll try and
Do you think
cover.
you should put it in there? I mean, but I can't give you, I don't
No,
know.
okay.
I have
I'll try
no
and
experience in that.
get an answer on that as to who should, because again, I think if we make it.
I guess my question is, what is the goal of this? Because if they know that there's risks to it, is it looking at changing their distribution or their location of where they have it? Because I think even more than sodas, it's a lot of the sports drinks and the things that people are
Right,
drinking. I see
right, right.
Gatorade, people think of, I'm not having a soda, I'm having a Gatorade, so this is fine for me to have because that's
Right, and
better
actually
for
that
me.
that would go in the information education side, right?
Sure, definitely.
Yeah. So no, I mean this really came up because of a recommendation that Senator Saud Anwar made, which is that, you know, one, obviously nobody expects that by communicating or sending a letter or whatever to a soft drink company is going to massively change how they practice their business, but it'll just put it on their radar that, okay, at a state level in Connecticut, there is some recognition that our products specifically are, so that's what it is. I mean, again, I don't mean to be naive to think that they're going to make big changes, but um, that's all it was really. And then number 7 is identify partners in Hispanic communities, community centers, churches, where the dangers of MASH can be highlighted. And again, this would not necessarily, I mean, identifying these organizations wouldn't take much work. I mean, that's probably not much more than a Google search, I would imagine, because I think most community centers and churches now would have some sort of a web presence. But the highlighted, meaning reaching out to them and doing something. I'm not sure what that would be. Perhaps sending some of these materials that might end up getting made.
Yeah, this is where I'll probably step in. At the Hispanic Health Council, we have a statewide nutrition education that travels to various locations, schools, places, and it's again it's state funded. I'm not sure what kind of changes need to happen up above, but we can definitely include it in our teaching when we go to different community centers and schools. We actually have a puppet show that teaches about the different nutrients. We can include the high fructose puppet in our puppet show so that children can learn about what high fructose sugar is. But that's something, that we can work on our end.
That's huge again, and this is all new to me. So can you give us an idea of the scale in terms of, for example, how many visits you might have? Like in a year, does this program end up visiting 10 schools or 20 schools or 50 schools? You may,
I don't have the exact numbers, but I think it's definitely over 50 schools, and
okay,
it's statewide, so it goes all over the state.
okay.
Let me get the exact numbers
Okay.
and
And it's
outreach
state
that we
support.
do.
Yeah, and
Yeah,
it's
and it's
state
state
supported.
exactly. It's state
Okay.
supported, so
Okay.
I think it'd be important. Again, that's us, but I'm pretty sure there are other people doing this too.
Right. No, that's anything you could share, obviously any of the materials that they might have, because we could potentially, submit all of this along with our recommendations and say, well, look, this is one, example of that. How many such state-supported sort of ventures or activities are there? Do you know? I mean, for example, is there a state-supported breast cancer awareness group and such like, or no?
I'm not sure about that. Yeah.
Okay. Okay. Um, Okay. Well, I mean, because it raises the obvious question about state support, right? That I mean, if the state does have a mechanism for supporting a particular initiative, then so okay. Okay. Great. And so if it's okay with everybody, we could turn to the one area that we haven't discussed. It's item 4 in the agenda, and that's the final topic that was given to us. And the topic is insurance coverage and affordability issues that affect access to treatments for such diseases. So, obviously a generic topic and obviously a very broad topic. And again, I'm thinking about what can we say about this that would be somewhat unique, right? I mean, it's obviously it's everybody recognizes this is a huge problem. And the affordability comes into even affordability for office visits. It's not affordability. I think people often think mostly in terms of medication affordability. But office visits have frequently co-pays of $50 or $100, which are not trivial.
I think similar to what Elizabeth was saying about um, raising awareness, although it may be sort of stating the obvious, maybe just pointing out the fact that lack of access to healthcare or insurance really can be detrimental to screening and diagnosis, especially because this is something that can be asymptomatic until late stages. But short of a really big initiative to increase access to healthcare, I don't know how else we could.
Right. So, okay. I mean, as you were saying that, what I was trying to sort of, again, to be practical about it, I was trying to sort of imagine somebody who we would most wish to help, right? So it would be somebody who's genetically at higher risk, which would be somebody in the Hispanic community based on the genetics of NASH that we understand. And it would be somebody who does not have health insurance. And similarly, And it doesn't necessarily, they may or may not have any language barriers, even if they don't have any language barriers. We'll assume that this person does not have language barriers. So how can we help this individual? You know, somebody who is, say, 40 years old, Hispanic community, you know, typical BMI demographics in the US, which means they're probably somewhat overweight, has no language barrier, but doesn't have health insurance. So how can we get that individual to at least get screened, right? Which of course is the first step, right? Because if you don't know they have a disease, you can't do anything else. How can we persuade them or help them, well, the state help them or somehow help them to, and let's assume they have NASH. Okay, this person has NASH with some liver fibrosis. How can we actually help them to, I mean, everything else we've spoken about up till now would help this person, right, in terms of outreach and materials and all the rest of it. But this topic is specifically about insurance coverage and affordability. I don't think we can do anything about insurance coverage as a working group. Affordability, the only way that I can think of affordability is if there's some way of free screening. You know, I mean,
Yeah, I was thinking the same. I'm sorry, I didn't mean
no,
to
please
interrupt,
carry
but I
on.
was
No,
thinking
no.
the same for number 4 with the massive statewide screening with the FibroScan for liver fibrosis. Would that be covered under individuals' insurance, or could we make that the free screening, at least so that people can identify they have the condition, and then from there they can try to collaborate with maybe the public health department or get some other coverage for the treatment? So would that be a free
Right. So
screen?
screening at the moment isn't amongst national guidelines. So it definitely would not be paid for, even if somebody had, you know, insured up to the eyeballs. The insurance wouldn't cover screening. So that would be, but of course, there's a difference between that item number 4 was for epidemiological purposes, right? I mean, it was to generate information that we frankly just don't have about the prevalence of this disease. But of course, in doing that, you would pick up individuals, so it would cover both aspects of it. So we could bring that here, that if you, I mean, I'm thinking about screening. I know Yale, for example, has a breast cancer screening van, because I've seen it. This van drives around and presumably does mammography. And that, I mean, to me, that would be ideal, right? I mean, to basically have a liver fibrosis screening van. I mean, I know for a fact that the FibroScan is not going to be as expensive as mammography equipment. That much I know. But we're still talking, you know, we're talking about an investment upfront of somewhere in the region of $400,000 and probably at least 2 FTEs continuing, you know, which would be another at least a couple of $100,000. So it's like a $500,000 upfront with 200 to 250,000 annually to operate something like this. But it would be fantastic. I mean, I would love to see you know, a liver fibrosis screening van.
From a statewide level, I'm not sure whether there's any possibility of working with, you know, the manufacturers, like, you know, the EchoSense, to see
That's
it.
a thought. If they would donate one.
Exactly.
Sure.
Exactly. Donate one, you know, for the public health, for the good of, you know.
Sure. No, that's fine. So, you know, even, okay, so you take away $200,000 because that's how much a FibroScan machine is. But I mean, we're still speaking about an investment of a couple of $100,000 up front, and then an ongoing annual cost of around 250,000. You know, you've got to upkeep the van and blah blah blah. And maybe we should just say that and be practical and say, just this is what we need.
Right.
It would take care of what you've asked for in terms of understanding the prevalence of the disease. And it would also take care of the issue of affordability, because this van would just show up at a particular community center and it would be free.
Yeah. That's one of the aspirational, you know.
I was just going to say you could use that as your aspirational for your Connecticut Liver Day if you had a free screening in a high-risk area that you know, Hispanic community that you wanted to, knowing that it would give you some credibility to the incidence and the rates. And then
Sure.
that could build as you move forward with potentially saying,
Yeah, and obviously,
justify why you need to like have insurance covered. I'm just saying
right.
things start at a sometimes small
Yeah,
level.
right. And I think that's one of our jobs, is to make a concrete suggestion that people can hopefully come around. And I think this would actually, I mean, it's obviously concrete because it's specific suggestion, and I think it would actually be useful as well. So
My
okay.
my thought is a lot of our clients do end up using some of the services like federally qualified health centers, free clinics. I know that Neighborhood Health from Hartford Healthcare opened up a kiosk that's free for anybody who walks into this kiosk. So they do use these services,
Yeah.
but rarely come in. Is there a way to incentivize a screening through QHCs or free clinics in a way that what would encompass a screening basically? Is it a specific test? And if so,
Oh, so fortunately, it's easy. I mean, it depends obviously how deep we wish to go, but the easiest would be to perform a fiber scan, which essentially feels like an ultrasound. And the actual test takes 10 minutes, but by the time someone gets situated and to fill in the forms and blah, 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 you would say 30 minutes. But they basically lie on a couch. They have to expose just the right hand midriff. There's a probe that goes on touching their skin for about 5 minutes, and that's it. You're done. And one wouldn't even necessarily need to do blood draws. In fact, I'd be like, fine, forget the blood draws, because obviously handling blood brings with it its own level of obviously safety and complexity with it. And the blood tests are actually not particularly good anyway. So
So let's say I'm a Hispanic client that goes through a free clinic. How can you incentivize the free clinic to, I guess, maybe a referral? Because they probably wouldn't do that procedure themselves.
no,
Um,
but so I mean, from a practical perspective, I mean, if a van would show up on a particular day, and would make it available, I mean, obviously they don't need to be incentivized to provide healthcare to their community, but in addition, if they got referrals, I guess that's an additional incentive. Did you have something else in mind in terms of
no,
incentivizing?
I was just thinking, I didn't know it was that involved, by the way. That's something we could do at a free clinic, like the screening itself. I thought you meant screening as in doing a questionnaire to do like a pre-screening questionnaire. So
Oh, I see, I see. No. So this would be a test. This would be like an ultrasound test, basically, because it's the most precise. I mean, questionnaires, unfortunately, just don't pick things up for
Mhm.
this purpose.
Yeah,
Um,
I think your van idea is probably the best idea so far.
okay. And again, it doesn't have to be van. I mean, the equipment is actually super portable. I mean, it's about the size of like a carry-on case, but that we carry on to airplanes. It weighs like 25 pounds. So with that, you just need a person, right? At that, and then you'd obviously need a room. So if a clinic would just make a room available, and that might be easier because obviously, vans are expensive and need upkeep and all that kind of stuff. Um,
What about school-based health centers? I mean, they
yeah.
often have a space at the school. You could get parents and students I'm just I'm
Yeah.
throwing out some ideas
Yeah,
for
no,
your
and so
wish
actually
list.
now that we're discussing it, maybe, a two staff members with the portable fiber scan machine might be more appropriate. And then they could go to, wherever's the only thing that the place needs to provide obviously is some privacy, and then just somewhere that a patient can recline. You can't do it on a chair, but they just need to be able to recline somewhere. Which, I'm sure a nurse's office in a school has something like that. I mean, children become obviously tricky, right? Because they're children and you need parents' approval before you start poking them and prodding them. But certainly, um, I
I
mean,
meant
there's
using
so many other
mentioning
places.
using this, like the schools that have a school-based health center, if you wanted to do a screening day and you'd let the school know and the
Sure.
parent would come.
Yeah,
If
for sure.
you've got a facility that's kind of sterile and clean
Yeah,
and
for sure. No,
you can often get information out through the school listserv, like,
right, right.
hey, we're doing a free screening on this Saturday
Yeah.
for families.
I mean, I just don't know. Are there any screenings done on children in a school environment? I just don't know. There are. What are they screened
They
for?
do hearing and vision screenings.
Oh, perfect. Okay. So this could be sort of rolled into that. Um, Okay. All right. So the best way I guess I can articulate this recommendation is that they're asking for two things: help with insurance coverage and affordability I don't have any good suggestions for insurance coverage, but for affordability, to recommend a screening program, and which would be 2 people. You'd have to have 2 people. One person's going to go kind of nuts driving around Connecticut. 2 people, and then a FibroScan machine, which is portable and they can go to various facilities. Which would be a cost, but and with that, honestly, with donations and all these other ways that monies could be raised, it's really, I mean, it's not pennies, but it's not an outrageous amount of money. I mean, it's a few $100,000 that can be raised through various ways. So we could even potentially apply for government grants and things.
Just for full disclosure, I have been trying to raise money for a FibroScan now for a couple of years, and I haven't made much headway, but I'm not a state of Connecticut, so.
Well, it doesn't sound like state of Connecticut actually tries to raise money for these things. But bringing it together with a liver health day and all the other things can make a world of difference. So, and maybe, Boo, you and I can speak about, there might be federal grants for equipment and such like, so.
Sounds good.
Okay, we are at the end. Anything else that people would like to discuss? So how many more meetings do we have? Let me look at my calendar. So where are we now? So December 4th. So we have one on the 18th, and that's it. We have one more meeting. And then 2 weeks after that actually happens to fall on the 1st, which is the date that we need to provide our recommendations. So I guess at our final meeting on the 18th, obviously will be a final run through all the recommendations. And also I think any supporting material that we can provide. It could be PDFs, could be examples of outreach, for example, from the Hispanic community, etc. So I think if we give concrete examples.
Sounds good.
Okay.
On the 18th, I'm giving a talk from 12 to 1, so I might be a little late in joining.
Okay. So I think the final agenda item was to announce the date of the next meeting, which is the 18th. If there's nothing else, then I think we can adjourn. Okay. All right. Very useful. Thank you, everybody.
Thank you, everyone.
Bye-bye.
Thank you. Have a good
Bye.
day.
Bye.